all the audience, because normally when we have this activity, even if we didn't force everyone to come on time or anything like that, this conference, this seminar is very well attended, and I really appreciate it. I'm really thankful for your interest in our program. Why? Because if you listen to this lecture very well, it will make you rich. You can be rich, see more patients, attract more patients than your neighbor or the dentist. See more patients in a more effective way, and do a little more troubleshooting, and you have a more solution, and your clinic will have better efficiency in seeing patients, not going back and forth, not having any round tripping. So it's good for you. Yeah. Good for you. Okay. Today, whether you like it or not, you'll be spending the whole day with me. And in the meantime, I invited one of the oral and maxillofacial surgeons that I'm working with, and he will be lecturing about the surgical procedure for impacted tooth. And we have a very good collaboration with each other. If I give him a cue, he will exactly do the surgical procedure exactly the way I want it. Exactly the way it's supposed to be. What do you mean by exactly the way it's supposed to be? If it's a surgical opening, it's a surgical opening in the bond. Well, he will bond the attachment and then extend the wire, and that's it. Is there anything else? Yes, there is anything else. But what we have to keep in mind is the close communication, collaboration between orthodontist and oral and maxillofacial surgeon. That's what we are going to discuss. But before that, we'll have a very brief warming up time for about 45 minutes to give you a little insight into orthodontic treatment, orthodontic technique. You may have seen this kind of figure, schematic figure, so many times in orthodontic textbook. Okay, right? This is so good, so good. So you are already ready to take pictures. It's so nice because without any thinking, you feel like, okay, this is a sequence of treatment. Number 1, number 2, number 3, number 4. And my question is, what is the arch wire for? What does it do? What if the tooth doesn't follow the arch wire? What should we do? So this is a typical example of a cookbook orthodontics. Cookbook orthodontics. What does the cookbook say? When you want to cook a meal, what does the cookbook say? First step, boil the water. Second step, put this and there for 3 minutes, and that's it. You don't know what 3 minutes means. Right? Yeah. So if it doesn't work, for some reason, if you commit a mistake in terms of amount of water or something, boiling time, and you don't know what to do. And that accident happens at all times. So problem with the cookbook orthodontics, you don't know what each step is all about. You don't know how to troubleshoot each situation, because orthodontics is never easy. Human body is different from each other. Your response is different from the other. And you'll have to figure out what you will do for this particular patient, even if you use the same protocol. Does it make sense? Yeah. Do you experience something like that? Yes. Alright, I follow the Damon philosophy. I don't know if there is anything like philosophy, and it's too sophisticated. I don't have a philosophy. I just try my best to cure the malocclusion, and there is no such a thing as philosophy. So the thing is, orthodontic tooth movement doesn't seem to follow guideline in the textbook. Why? Because it's biology. Example. Very simple. Perfect dentition. The only thing is the upper center incisors is broken. Okay, I don't want to pull this out. Well, you can try forced eruption. Forced eruption, right? What does the textbook say? What does the textbook say? Exactly. There's nothing wrong about it. Nothing wrong about it. I want to drag the central incisor just a little bit, 1 or 2 millimeters, to be able to expose the margin to get the post-core crown and things like that done. Anything wrong? Nothing wrong at all. Nothing wrong. In 2 months, this happens. Why? Who did that? Who did this stupid thing? Yes, I did. I did. I did. Why? Because the textbook says this is what I'm supposed to do. And I did, according to the guideline. Is there anything wrong? Did I do anything wrong? Yes or no? There's nothing wrong. This happens, and this complicates my treatment procedure because I have to. Now, okay, I'm an orthodontist. Now, just because I see open bite happening, well, I'll have to reinforce premolar and molar, this and that and that. Eventually, we ended up with a whole arch strap up, leveling and alignment. I can do this because I'm a professional orthodontist. I can, cope with the situation. Eventually, I did. But what's the take-home message out of here? Reality sucks. Different from textbook. We have reality, and we are working. So, what is this? How would you? Anyway, you can show this clinical case out in this conference. We did it. Okay, it worked. So we were able to. We said the post and core and crown and things like that. Okay, done. But if you take a little step into the exact treatment procedure, this is a result of our agony, trouble, struggling, things like that. I don't want to see this happen. Why does it happen? Why? Very interesting article published by a Chinese group, and let me brief this out because this is a little complicated, may feel like a little sophisticated. They tried the 3-dimensional culture of the periodontal ligament cells. Periodontal ligament cells, under certain pressure, they are supposed to excrete some markers. The markers that initiate osteoblastic and osteoclastic differentiation. So which may be an indication that, okay, these cells are ready to initiate the bond remodeling. So if you find red spots, these cells are ready to initiate bond remodeling, although it was an experimental circumstance. So they wanted to see the differential response according to the Monto force. This was supposed to be optimal force in clinical set point, 25 gram per square centimeter. 2 week, okay. It is very natural. At 6 hours, there's a little difference, yes. But as time goes by, even under 5 gram force, they start to differentiate. This is what's happening. Why? Because the cells, as long as they are under certain pressure for a certain period of time, they're supposed to respond. They don't recognize, okay, now I recognize this is 5 gram, okay, just because it's 5 gram, I would not respond even if the pressure comes for the next 2 or 3 days, I would not respond because I recognize this is 5 gram. Does it work that way? Do they recognize, okay, it's 5 gram, okay, I'm not going to respond. Oh, now it's 6 gram. I have to start working. Does it work that way? They don't recognize the 5, 10, 15. As long as they are under certain pressure, fascia, it will start to work. So what does it mean? Even if the 5 anchor teeth to be able to drag the central incisor down, let's say you use of 150 grams for the central incisor. Mathematically, 150 grams will be distributed onto 5 anchor teeth. Is that correct?
Yeah.
Divided by 5, 30 grams for each tooth. So then the question is, would the anchor teeth respond to 30 gram intrusive force? Initially no, but eventually yes. This is a reflection, okay? Does it make sense?
Yeah.
Very interesting. What's the first lesson? Tooth anchor is very deceiving. Tooth anchor is very deceiving. And orthodontics is never ever a mathematics. Never ever a mathematics. What does the conventional orthodontics teach? What do they teach? Okay, if you want to retract the canine, basically you have to prepare the anchor by time. Second premolar, first molar, third molar as one unit. They will be strong enough. No, they are not strong enough. They are not strong enough. They are supposed to move forward. Not initially, but eventually. But you are doing orthodontic treatment for at least 6 months, 1 year of time. In the meantime, the anchor tooth must move. Must move. Is that correct? You understand?
Yeah.
If you are obliged to, without any other choice, if you have to use the tooth anchor, try to design a very heavy anchor unit. You really have to keep an eye on the anchor teeth as much as the movement of your moving tooth. Because they are moving at a similar speed. You have to be very careful. One more example. She had a impacted tooth, single impacted tooth, second premolar. She visited university hospital at another city. She had been under treatment for more than a year. Just because it was a university hospital, her treatment record was very well documented. So this is very initial. And impacted second premolar. She's only 21 or 22, early 20s. So there's no problem with the age. And I guess this is not really ankylosed, but we have to be suspicious. They did surgical opening. They prepared anchorage segment this way. They tied up 1, 2, 3, 4, 5 teeth as anchor unit, only for the sake of saving impacted second premolar. Is there anything wrong? This is exactly according to the Bible of orthodontic treatment. There's nothing wrong about it at all. And this is what happened when she came to my university hospital in here. Not because there's any conflict or lawsuit or anything like that, just because she had to move to another workplace in Seoul. So she came to Seoul, and she came with all the documents with her. And this is what we saw. Is there anything wrong? What do you suspect? Maybe ankylosis of impacted second premolar. Let's have a look at the panoramic. Was it ankylosed? No, not ankylosed. Is there anything wrong? How many teeth did they use as anchor unit? How many teeth are included in anchor unit? 5, including 1 big lower molar. Is there anything wrong? No. You can never ever find anything wrong in terms of orthodontic technique over here. And the tooth was not ankylosed. So what is wrong? fight between 1 versus 5 anchor teeth. Due to mathematics, there's nothing wrong. But this is a biology. This is a biology. I'm not saying that, oh, well, the nature is so diverse, it's so unpredictable, so anything can, no, I'm not saying something like that. So very initial in our university. What is the take-home message? She was 21, she was 21 or 22. This is a very bizarre animal experiment. So the authors did transplantation of a dog's jawbone segment from one to the other, from young dog to another young dog, from young dog from another old dog. Very bizarre. But they wanted to see the eruption rate, whether it changes. Although the segment itself was from the very young dog, the tooth jaw within the bone segment was supposed to keep erupting even after transplantation. And the result was young dog's jaw segment that was transplanted to another young dog's jawbone shows normal eruption, while the other segment that's transplanted to another old dog doesn't show tooth eruption. What does it say? So what's the message out of here? Even if the segment itself is fresh enough, if it's transplanted to another old host, the central regulation would resist normal eruption because there is no signal, there is no cue, there is no order, much less order, much weaker signal or something. That's the core concept of this experiment. So even if the premolar was not really ankylosed, so-called eruption potential must be diminished, must be reduced very much. Is that correct? It still responds to extrusion force, yes? But the eruption rate must be very, very, very low because she is an adult. The second premolar was supposed to erupt at around 12, 13. Now, although she's not 50 or 60, 50 or 60 will be worst case scenario. She's at 21. Okay, so the second premolar is going to erupt, but eruption rate will be very, very low, slow. So in the meantime, the 5 anchor teeth, including one deep molar, will be sinking down. Why? Because they are also surrounded by the periodontal ligament. Don't underestimate the function of the periodontal ligament cells. Do you get it? Up to this point? Does it make sense? This is a part of biology, and I think biology. So again, if you come again next year, I will take a deep step into the biology to give you a little more solution for very trouble case like hyperdivergent case, long face, class C. There is a pain in your neck, right? If you take a deep look into the biology, you'll find a very, very odd and hilarious solution out of it. That's very, very exciting. But I'll show you some of the examples this time. So, lower molar intrusion is probably the hardest type of tooth movement, and it happens only when I don't want to see it happen. Right? Oh, it was a joke. You don't laugh. You're being too serious. What happened? Alright. Lower molar intrusion is probably very difficult to achieve, but it happens as a side effect many times. And it happens. Isn't it strange? Have you ever tried lower molar intrusion? I do it sometimes. And it's very hard. And it works, but it just happened during premolar course eruption of the premolar. Very strange. So what am I supposed to do? I remove all the braces, and to my surprise, the most pleasing type of relapse relapse just happened. Normally relapse is bad, but this time I really welcome the relapse from all the other people. And to eliminate the possible side effect, I asked her to wear the rubber band. Following full extrusion of the premolar, now we started a tiny little amount of derotation of the premolar. This is a sequence of the treatment. Try to get rid of a side effect, and side effect happens without exception, especially when you use the teeth segment as your anchor unit. So the same thing. Probably I'm not going to talk a lot about clear aligner thing this time because until I find a very good solution for the biomechanical limitation of the clear aligner, the irresistible biomechanical limitation of the clear aligner is that it produces reciprocal force, reciprocal. Even if, like I told you yesterday, even if you want distalization, I mean, it pushes the molar and also pushes the anterior teeth forward, and there's no exception. Unless you effectively combine the mini screw with the clear aligner, but then the patient has to assemble all these segments within the mouth, engaging the aligner and also elastic and this and that way. That's too much work for the patient. I will find the solution, so hopefully I will come back to you with a very good solution so that you can use your clear aligner without worry about, burning anchorage or something. Maybe next year, okay? I'm working on it. But this is the reality, and without any consideration into the underlying biology, we may be in trouble. Do you think it's a big trouble? Big trouble enough, right? This is a big trouble. This is a big trouble. Why? Because the patient expected it. The patient heard in the very first beginning, patient heard that this is a minor problem. Okay, single tooth, all the other parts, occlusion was okay. Single tooth was supposed to be single tooth. Now, there's a burning anchorage, molar. Hey, Dr. Lee, I cannot chew on the left side. Was okay in the very beginning before you started orthodontic treatment. Now I'm in trouble. What happened? What happened? Only to me. It's only my case, or something like this happens to others, another person. My God, stop asking me. Let me focus on your treatment. So, unavoidably, you have to use the mini screw. Back in 2002, 2003, we started to use the mini screw, and somehow I had a feeling that, well, like the brand new type of brackets, this may just be a fashion. It's powerful, but maybe a fashion or trend, it's a transitional trend. Sometime later, we'll be using some other device to replace the mini screw. I don't know how long it will go. I'm still working with it. And as long as the anchorage matters, you'll have to use the mini screw maybe in the next 20, 30 years of time, right? So, I couldn't get away from it. Try to think about your own appliance. She lost central incisor. The prosthodontist wanted to save the canine. The margin was subgingival. They wanted us to extrude the canine. Well, not a big problem, but technically there's a little bit of obstacle because the tooth material is so small, not easy for us to attach any attachment, not easy. So, like the first case, like the case before, first we asked her to engage a rubber band between the mini screw and the hook. Was not easy, because this is the anterior portion. It has to be aesthetic. So we asked her to do this, but for was not easy to find the hook behind the pontic. Not easy. Theoretically, yes, but there's a technical problem. So, like I told you yesterday, we wanted to devise compliance-free orthodontic appliance. Compliance-free orthodontic. This is all creative area, and I wanted to do something. Okay, first step: what is the target segment? Single tooth. What is the type of force? Extrusive single force. It has to be very, very extrusive vertical. There may be ways. So now, force from the elastic band from the lower mini screw and the force from the helical spring, although they look different, the force system they produce is exactly same, almost same. Does it make sense? So what is going to be your first step? Try to draw an arrow, whether it's going to be this way or the other way around. And let me tell you, this arrow, to my lateral side, is different from this arrow. Do you agree? Do you agree? This is important. You have to focus on the point of force application. Force. Same amount of force. Are they same or different? Very different. Very, very different. Okay, one more question. Force, 100 gram. Force, 100 gram. Are they same or different?
Same.
Exactly same. Why? Because they are on the same line. That's what we call law of transmissibility. Law of transmissibility. The force vectors are identical only when they are on the same line of action. Okay? If they are not on the same line of action, they are very different. So what do I mean by different? They will show very different clinical outcome. This will produce rotation. This will produce translation. Very simple. Hey, Dr. Lee, that's too simple. That's very low. Basic biomechanics. Yes, that's a basic biomechanics. But I see, even among my residents, even if I keep telling them, draw an arrow, they don't seem to do it at all times. Why? I don't know. Maybe it's not, they think it's not useful. Yes, it is useful, very useful. I draw an arrow, so based on the arrow, I design an appliance this way. Again, what matters is the force system. Simply draw an arrow, and based on arrow, you will design an appliance. In order to fix the single helical spring, then single mini screw would not work because it's not supposed to fix the helical spring. So I inserted 2 mini screws. And it worked. Gradually margin is being exposed. You see the relative extrusion of the canine. Following a little bit of the relative position of the root apex compared to the border of the maxillary sinus. Following some minor adjustment, now the margin is exposed. The prosthodontist was able to do the crown, finalize the crown. Okay? We'll briefly talk about molar uprighting now. Keep this thing in mind. Molar uprighting. We are still in the warming up phase. We'll have a more exciting case in the afternoon, in the morning, and I will go through the rocket geometry thing. I will do my best to make this understood. That's why you are here. You spend a lot of money traveling and you had all these bureaucratic problems going through the vaccination, immunization forms and things like that. I don't want to do it one more time, but you came here to feel something, And I have gadgets over here, so you'll have to feel, manipulate with the models and the wires, and it is important. And even if you see the slide 100 times, 1,000 times, there may be limitation for you to understand. You really have to understand, okay, that's how it works by tinkering with your finger. Okay? I will let you do that. For molar uprighting, what do we need? Maximum rotation. Right? Maximum rotation. For maximum rotation, we'll place the line of force away from the center of resistance. Is that correct? Away from the center of resistance. This is a very good example in the orthodontic literature, and we know how it works. Uprighting spring. And my question is this good enough? First thing is, there's a side effect. We know that. It is already described in the textbook. Second thing, do you like this? You like this. I don't like this. I don't want to extrude. So you do this kind of thing, okay? Root spring. We call it root spring. By bending another helical spring, activating the medial and distal side, exactly the same angle. There is no extrusion, but pure rotation and rotation. Is it good? Is it good or bad? Is it good or bad? Just because I know that the regular uprighting spring is fatal, very bad, we decided to use a root spring. We ended up with an open by transverse problem as a result of a molar uprighting procedure. Very bad. Have you ever experienced something like this? Do you think molar uprighting is easy? Not easy. Not easy. Because as if it's, we are missing something. Obviously we are missing something. That's what I'm going to talk about in the morning, alright? Molar uprighting is not easy. Never easy. In most cases. Why? Because the upper molar is in the way. We cannot possibly upright the lower molar without getting the lower molar bumping up against the upper molar. If this is interfered by upper molar, open by tongue thrusting, some transverse problem, bad habit developing, oh my goodness, this is really terrible. We need a differential diagnosis. They are different. So I classified this into two categories. First one, primary mesial angulation, which is mesial angulation of the lower molar in the middle of eruption. Yes? Okay. In the middle of eruption. That's primary. Secondary mesial angulation, even if they were erupt very at perfect positions, following the missing or ankylosis of the first molar, they're supposed to tip forward. And that's what I call secondary mesial. Because it's a secondary, okay, I get it. Well, what's the biomechanical difference between these two? Primary mesial angulation would allow us to introduce extrusive movement. Is that correct? Extrusion is allowed because there is a room on top of it. Secondary mesial angulation would not allow any rotation, extrusion, or anything like that. Very cruel. Secondary mesial angulation is not forgiving. You have to be very, very technical. You have to be very, very meticulous in terms of the force system design. Okay? But I will tell you how in the morning and in the afternoon. This is not going to work. Uprighting spring, continuous arch wire, none of them, neither of them would work. before we discuss that, show you a couple cases. This was published in the Journal of Clinical Orthodontics long ago, but still I have to explain it one more time for a drill. So, mild mesial angulation. What does it need? Rotation. Rotation. Maybe you can twist the second molar, but not easy. How do you think you can twist the second molar? Not easy. But if you give a single force, you'll be able to upright it. You'll be able to upright. You don't. This is too complicated. In this force system, you know there is a side effect. We want to get rid of it. Okay, I'll use a minuscule. Second thing, I'll use a single force. Just imagine, this is a mild mesial angulation. This is exactly why I told you to draw an arrow, draw a line. Estimate the distance, maybe 7 or 8 millimeters. Why? Because it's a mild mesial angulation. Try to follow my arm. Try to follow my arm. So, my question is, if it's tilted to the mesial side even more, what happens to the distance? Does it increase or decrease? Does it increase or decrease? Decrease. Correct? Decrease. Which means the single force is not going to work for severe mesial angulation. Does it make sense? This is important. But you don't. Very few of you seem to draw an arrow at all times. In the panoramic view, I do it, draw an arrow. And the distance must be at least 7 or 8, 10 millimeter. So if you give it 100 gram force, the uprighting moment would be 1,000 gram force. 1,000 gram millimeter or something. That's probably good enough to cause some rotation. So this works for mild mesial angulation only, okay? So you design this kind of uprighting spring, I don't know, I just named it because I created this. Mini-screw assisted push spring, MAPS, M-A-P-S, mini-screw assisted push spring. This is the way how it's fabricated on the chair side, insertion, and bending the wire, 016 stainless steel, pinching a crimpable hook, and then open core spring. The whole setup will take you only 10 minutes. On the chair side, you don't need to take an impression. This is what I like. I don't want to take an impression. I don't want to send a model to the laboratory. I don't want to spend a day or two to get the appliance done. I do it on the chair side. Done? But if it's a little more severe mesial angulation, the case will be different. Similar but different. Similar but different. Do you think it's different? Yes or no? It is different. It is different. You have to recognize the difference. Little more severe mesial angulation. Little more severe mesial angulation. What do we need? We still need moment, okay? This is a primary mesial angulation. So you may try a pure rotation. Now, this is the difference. Where is the center of resistance? Over here. If you put an attachment here, now, if you put an attachment here, you imagine if you use the retromolar mini screw, this is going to, but technically there was a third molar. Biomechanical, this is way better. Think about the distance. This is 2 times difference. 2 times difference. and you're supposed to use only around 100-gram pores. With 100-gram pores, this will create 500-gram millimeter moment. This one, 1,000-gram millimeter moment. That's the difference. I don't know whether 950 will make a small difference or something, but this is a very, very radical difference. You have to understand it. And you do this drawing, and based on this drawing, you will decide where to place the mini screw, how to ask what to ask to your oral surgeon you're working with, whether you expose the red distal side or mesial side or something. Is this going to work for this case? Yes or no? No. This is going to work. Yes. This causes extrusion, but just because this is a primary mesiangulation, we decide to use this. First, I still use the maps. Why? Not expecting to see the molar uprighting, just to release the mesial side of the second molar from the distal side of the first molar. Okay? Just for the sake of release. This is not going to upright the lower molar. Then effectively, molar uprighting will take place if you use a molar uprighting spring. This is a sequence of the treatment. You have to be a little more specific. This is a sequence of the treatment. Just because we are running out of time, keep one question in mind. In the first case and second case, we did not pull out the third molar ahead of time. Think about why. There is a reason. There's a reason. You probably know the answer. Yes, because you came here for the third time. But I'm going to give you another lesson today. So this is the sequence. We were able to upright the second molar this way. So the strategy and tactics have to be different according to the degree of mesiangulation. Okay? You're still following? Everything clear?
Yeah.
So, first case, second case, they are very different. You have to understand it. And I'll show you this case after his lecture, and try to think about how you troubleshoot the situation. Second molar, third molar, and think about which one you want to extract, because we're not supposed to save all three teeth, right? We have to pull out at least one out of three. Think about the solution, and if you, for some reason, if you want to upright the second molar, what mini screw you will use and where you would place the mini screw and things like that. Or if you want to pull out the second molar to rescue the third molar, what you would do, right? We're not supposed to save all three molars. Think about it. I'll give you the answer after the break. All right?
All right.
Leave this question mark, and I will hand over the microphone to the next oral and maxillofacial surgeon that I like the most in the university hospital. Okay. Okay. Professor Wonsa Park is the oral and maxillofacial surgeon. He's probably doing the most third molar extraction in the hospital, and he's closely working with me for most of my impacted tooth cases. And after his lecture, we'll have a coffee break for about 20 minutes.
Good morning. My name is and I'm working in the Department of Advanced General Dentistry. And thank you for invitation to this course. And my lecture may be talk about to you about the infected tools. The detailed topic is alternative friendly surgical game. Opening, but my lecture will be two parts. One is the differential diagnosis and the various treatment plan of the infected tooth, and the second part may be the detailed technique of surgical opening, the rescue surgery of the infected tooth. So I was trained in oral maxillofacial in Yonsei University, and then I worked as fellow and clinical professor at department, and then changed my position to the Advanced General Dentistry, a very similar program of the AUGD or GPR in the United States. And I was trained in oral maxillofacial surgeon, but basically I am not oral maxillofacial surgeon, just an oral surgeon. So just an introduction of my thing. And as you know, the infected tooth is different with the embedded tooth or infected tooth. There are some different terminology, but usually we talk about not erected tooth, is infected tooth. So most of the infected tooth is third molar and the canine and the mandibular molar actually inside there. The clinical feature of the infected tooth is remaining diseased tooth and infected canine or the third molar, and there is sketching of the tooth, and with or without the pathologic change related with infected tooth. So in canine, we usually save the tooth, so we do the surgical opening, the rescue surgery at the same terminology, and then we finalize like that. Not only the canine, we can do the every infected, save every infected tooth, such as this kind of mandibular molar, infected third molar, and attach the orthodontic appliance to the mandibular second molar, and we finalize like that. But usually we extract the infected tooth when the infected tooth cannot be maybe useless for the function or something. So when we diagnose this, some kind of pathologic thing, such as the cystic lesion or the tumor or something, we have to you have to make the different diagnosis. But in terms of the infected tooth, differential diagnosis is very easy. Just infection is that kind of thing, right? But the importance is treatment planning may be very different. The orthodontist want to save the all infected tooth, and the oral surgeon may have tend to extract the tooth, and the endodontist have a very high tendency to do the transplantation or something. That is the different thing. That I mean that what can I do? What can I will do kind of procedure what I am very good at, right? So that's the problem. So I think the collaboration is very important when we make the treatment planning of the infected tooth. So generally, we can do the make the treatment planning like this one. The most extensive one is the lower side, the extraction tooth, and put the implant or bridge or something. And the invasive one is the first one, no treatment, and just leave it. And then there are, when we use the infected tooth, we can choose three options. One is surgical opening, and then do the orthodontics. And the second is autotransplantation. And very unique thing, one choice is decompression children. I will show you some cases about that. And we have to think about some considerations of effective tooth treatment planning. And the first one is time, second one is the money, third one is the patient, and the patient will to get the treatment, and the third one is the technique. Okay? As you know, I told you the treatment planning is very important. This is a failure case of the treatment of infected tooth. Originally, we this is not my case, another surgeon's case. Surgeon wanted to extract the infected tooth and then implant over on there. But when he raised the flap and saw the infected tooth, the tooth was so sound at the operation site. So he changed the mind at the operation. You have to save this tooth. This is very good tooth, so you have to do that. I will put the tooth in your mouth, and then we will extract the tooth. So patient agreed about that. But the problem is the surgeon has no idea when to start the orthodontic treatment. So the patient was leave for several months, and then referred to orthodontic clinic, and then this is final. The tooth has enclosed at the transplant site. So we did the segmentotomy to move the. Is it okay? To move the canine, but the 괜찮아요? 여기 열면 그런 것 같은데 아닌가? 괜찮아요? But the patient has spent time and get some temporary procedures, but the result was not so good. So consultation with specialists is very important, and collaboration is very important in this case. So basically, you have to think about the treatment planning. You have to consider whether we can you hear me? Okay. Whether you use the infected tooth or extract the natural tooth. So there is a risk for the preserving of natural tooth and the benefit of the preserving the natural tooth. So if you once think that the natural tooth or infected tooth is not good for preserving, you have to think about the implant treatment or the process treatment. And then once you decide to preserve the natural tooth, you have to think about the risk and benefit of orthodontics or the autotransplantation. And this may be very different from the technique of the orthodontist and the surgeon, and the time, and the money, and the patient will. I will show you some cases with the canine. This is the first treatment option for the canine, infected canine. Usually we can't talk with this kind of thing with no treatment, but you have to write on your record is observation for the follow-up. You should not write the no treatment option, no treatment like that in your medical record. Sometimes there may be another situation may occur, such as a pathology change or something, and then patient will criticize you. You told me that the treatment will be not needed, but you were wrong. So read the infected tooth, the treatment planning should be observation or the follow-up. We do observation or follow-up when the patient had no will to get the treatment or the old age. She's 51 years old and she has an infected tooth, and her chief complaint was just a fracture of the deceased canine. She had no idea of infected tooth of the canine, so she was not motivated at all. She wanted to know about the extraction of the first the central molar, central incisor, and the distal tooth, and then make the processes of fixing the bridge or something. Then why did you came here? I asked to her, and she told me that is it possible to remain the tooth? So okay, you can do that, and you can extract about that. But only one thing you have to get in mind is there may be a very little chance of the pathological change of tumor or cyst. So you have to get the general checkup and the taken small peripheral X-ray, and there may be very less invasive treatment option for you. She was happy about that, and she was gone. And another case is very similar one. He was the 64-year-old, and also he had no idea of infected tooth. You can see the ankylosis of not only the root portion, but the coronal portion is also ankylosis. So if you see this case, you should not do the orthodontic treatment at this canine or the infected tooth. We have later I will show you the result of our surgical opening case. Only one thing that affects the result is the age. Age is only one thing that the successful or failure of the surgical opening. And sometimes this case may refer to my clinic. The general dentist wants to put the implant on the full maxilla, but when he drilled on the canine side, he felt something different. And then we found that there is a infected canine or something. So very ridiculous case, right? He had no idea of the analyzing the panoramic X-ray before putting the full mouth X-ray. So I asked about the patient and the doctor. Are you planning to do the implant on that side? Okay, I will do the implant on the left canine side. Then I extracted this kind of thing. I raised a more larger flap and make the opening at the canine infected tooth, and then just pull out the tooth and then graft it on the side, and then this is final thing. So this kind of technique may be beneficial for the future implant placement. This is just a technique of the extraction of the tooth. So the most invasive option is the extraction of the infected tooth. So we extracted this infected tooth canine when the deciduous canine is good, or the orthodontic treatment may be very hard in terms of prime mechanics or other patient view or something. The third treatment option is the decompression. Decompression is only available on the child who has about the age of 8 to 10. He came to my clinic. He liked this one. This is infected tooth, and there is a very huge size of the cyst around that. You can see this kind of thing in CT. There is a buccal expansion and the movement of the premolar, and there is a nose, and there is a tooth, infected tooth. So in this case, we can inoculate all canine and cyst and the premolar, but it may be very invasive procedure. So what I did is just to make a very small hole and make the entrance, maybe not the entrance, the exit of the cystic cavity fluid, and then I made the follow-up and change that. You can see the change of this kind of infected tooth, and the infected tooth was erupted, and then we do the orthodontic treatment, and the final thing is like this one. Okay, only this may be available when the cyst at the region is the cystic cyst, not on the tumor or something. So you have to do the biopsy to confirm the pathologic region. This is another case in the mandibular disease molar. So there is large cystic cavity, but we extracted this disease tooth and applied the delivered the appliance, and then the tooth has come erupted. And then final thing is like this one. Okay, just leave it. Just remove the source of infection and deliver the appliance that we can remain the cystic cavity opened. Okay. This is another case also. This is also a 7-year-old boy, and there is an high infected canine. Very similar case. We can do same thing, that we delivered the removable appliance which has contained some kind of tube. So then the tooth is moving like this one, and the final is like this one. But you have to keep in mind that when the right side canine has come out, there another side, the left side canine, there is another cyst. So we remove these two tooth and inoculated the cyst, and then canine has come out. Okay, so this is the treatment planning of number 3, decompression, only available in child and who has the cystic region. The amount of the movement of infectious is not a big problem like this one. Okay. So I will go to the main topic of the surgical opening procedure. That is the rescue surgery and the orthodontic treatment. And that the success key for the surgical opening and the orthodontic may be affected this kind of thing. Most important thing is age. I told you about that. And the second one is that there is an ankylosis of infected tooth. And the third thing is the curved root of infected tooth. I will show some failure case at the end of the lecture. And you may see what the curved root may affect the success of surgical opening procedure. So age may be very severe, the most important thing. So this is a young age, about 11 or 12 of age. She has two infected tooth, but is it relatively easy to pull out this canine? And the second one is, second important thing is the patient occlusion is not fully set up. So there may be a chance of we can push the premolar distal side, or we can pull the premolar or something. But compared to the kind of the young age, this isn't very 40 years old. She has an infected tooth, and there is a very small another supernumerary tooth, and there is tissue tooth. We may do the surgical opening and track the infected tooth. But you have to keep in mind that once we decide we track this canine, we have to make some major distal space for that kind of thing. So we have to change her occlusion at the left upper side, right? Sometimes it may be very difficult, and it may cause the patient discomfort or something. So once you you can try, but when you try this kind of thing, you have to say about you may use that impacted tooth, but there may be change of occlusion of your tooth area. Okay. And I will show some clinical procedure like this one. And this there is an impacted canine on the left side. And there is a small amount of root resorption, but we do the pulp vitality test before the surgery. But when the vitality is present, we do surgical opening, and then we remove the chance of the external eruption, this kind of thing. So there was slight root resorption in this case, but after the treatment, the resorption is stopped, and she saved her anterior tooth. So this is CT. You can see the resorption, but the vitalis was intact. Not only the cold test, but EPT was good. So we tried to rescue the left canine. So this is thing. And once we make surgical flap. I like this kind of thing, circular flap, and make the vertical incision at the distal side. This is labially impacted thing, so when you raise the flap, you may not see the impacted tooth, but this without using any other drill or something, I can put the very sharp surgical instrument such as the explorer or the surgical curve or something. There may be a very crack of the cortical bone, and we may find the location of the impacted tooth like this one. And then we remove the soft tissue around the impacted tooth, and then our orthodontic resident come to our department, and they do the etching and drying and applying the bonding agent, and they apply the orthodontic button like this one. And this one is very, the left lower side is very important, but when you attach the button on the impacted tooth, you have to test the button whether it is very good or not. Once you close the flap and then the button was not fully attached, there may be detached of the appliance, then you have to reopen the case. So she did very hard movement on the impacted tooth and test the button whether it was attached good or not. Okay, and then she did an additional curing procedure about that. And after the orthodontic procedure, I usually do another surgical procedure like this one. Can you see that? The color was red, so I will change the color. Okay. I remove this area bone. I remove because the movement should be done of the bone at the yellow area. So I remove that kind of bone to enhance the movement of the impacted tooth. But this kind of procedure should be done after the attachment of the orthodontic appliance, because there may be a lot of bleeding come to here, so it may be adhere, and it will prevent the good attachment for the appliance procedure. So you have to do it later. Sometimes I do extract the deciduous tooth, this kind of thing, at the procedure, but also I do that kind of thing in the later of the button attachment. So after the operation, we took the periodical view like this one and the movement like this one. Okay, this is final thing like this one. Okay, there may be other. We can see some kind of the root curvature like this one, but it is good unless she get an endodontic procedure, right? So we educate the patient. The root, we save the tooth, but there may be a chance of the curved root and maybe a very difficult situation may occur when you get the endodontic treatment. So you have to brush your tooth and keep your oral hygiene very important. This is another case of the central incisor. There is many problems, not only this kind of thing. There is a root like this one, root remnant in here, in here, in here, and here, right? So usually when we make treatment planning, we extract all root remnant and the infected tooth and put the implant on the dental site. But I consulted this case with Professor Lee, and I think Professor Lee is some kind of magician. He asked me to do the surgical opening like this one, and extracted all root rest, and then he changed the direction of the anterior tooth like this one. He did another thing, that he closed the area of the root remnant here. He closed here, he closed this space, and patient got only 3 implants on here. That is the final thing, but it is not an important topic today, so we do, I will talk about the surgical procedure like this one. And you have to take the combined CT or CT before you do the surgical open procedure. First one is you have to check whether there are some pathological change is present or not. And second one, you have to see the ankylosis of the infected tooth. And the third one is like this one. There may be some malformed tooth on infected tooth. You can see this kind of thing. This thing is very not usual, but you can see the result. We made a vestibulation like this one and opened the bone, and you can see this one, right? All infected tooth may be not good situation in the bone. There may be a defect on the crown side, so there may be a chance of the additional treatment, such as the lesion filling or something. And if there is some corona defect or the structural defect on the infected tooth, you may get some difficulty when you attach the orthodontic appliance because of the abnormal structure of enamel. Okay, so you have to keep in mind, and you have to take the picture at the operation time and instruct the patient that you have the abnormal tooth shape or structure on the infected tooth, but we may track the infected tooth on the ideal position, but you have to do, or you may do get the additional treatment after the position is aligned, tooth is aligned. And I will show another picture about incision design. One is the clavicular incision, like this one, and like the vertical incision. The another is just do the vestibular flap. I prefer this kind of thing, but the infected tooth is very high. I have to do this kind of the vestibular incision, but this is photo when we when we start to make the suture. When we make the vestibular incision, there may be bleeding about that, and the postoperative sequelae is more severe on the vestibular area. So I like this one, but sometimes we extend the wire. It may be very easy when we make the vestibular incision, just to leave the wire came out from the incision line. But when we make the vertical incision and the clavicular incision, we have to make the additional step incision like this one and pull out the wire like this one. This is a technical tip for that kind of thing. And the final case is the palatal infection. So palatal infection is a little bit difficult because the palatal flap is very hard to raise, and the position is not so good. So sometimes the dentist have a very severe pain on the neck side, so we have to extend the patient head to the distal side. After making the raise the flap, we do this kind of we use the 1.5 side round ball to remove the bone tissue covering the infected tooth, and we open the infected tooth and then attach the orthodontic appliance on the infected tooth. You can see the defect of the bone tissue in here, right? This is the same thing that I removed the bone tissue, which the infected tooth have to go. I made some additional thing like this one. But when we remove this kind of thing, we should not touch the adjacent teeth. So at least I preserve 2 millimeter of space at the adjacent teeth to prevent the bone eruption or the black triangle around the adjacent teeth. So in summary, you have to keep in mind in the surgical opening procedure. So sufficient visualization is very important. So I usually do the vertical incision and expose only corner portion with the round bar or the hand instrument like the surgical cradle or something. You should not touch the PDL or root portion. Once you touch the root portion, there may be the resorption or the ankylosis may start on there, and then maybe it may be not good for the prognosis. And when you meet some pathologic thing, such as cyst or tumor around the infected tooth, you have to remove that kind of pathology at the surgical procedure. And the most important thing is this one. The orthodontic appliance should be attached firmly, so the strict bleeding control is very important. So I do very strict surgical procedure, and sometimes I use the anesthetic appliance, anesthetic solution, which contain the high epinephrine, about 80,000 epinephrine. That may be good, short time of the bleeding control. And I told you that I removed the bone for that kind of thing. And then I have to discuss about the wire extension with my colleague, the orthodontist. And sometimes I have to think about whether I decide the time of extraction of the adjacent permanent or the deciduous tooth. That's the consideration factors about that. So there are little literature about this kind of thing. So you may see the technical difference about the such a procedure, labial or palatal, and the gingivectomy and the apical position flap or the closed flap or something. And they put the Bedona and Park published in the JADA in 2009, and it's a very good article. So you may find that kind of that literature. But surgical opening is not always success. So the important thing, the different thing is perineal procedure. When we succeeded to change the position of the infected tooth, but there may be a very insufficient attached gingiva around the infected tooth. And I showed the MAH05963 case, and the most important failure is that we failed to move the infected tooth. There may be a resorption or the open bite and the bottom fallen out, or then that may be caused because ankylosing is the curved root. Okay. So this is the I'm preparing a manuscript about surgical opening procedure. So we did about 225 cases, and there is 7 cases of the failure, and there is a reopening procedure about 25 cases. When we do the surgical procedure, surgical opening procedure, there may be a chance of 10% of the reopening surgery, and there may be less than about 3 or 4% of the failure of this kind of thing. When we fail the surgical opening procedure, secondly we think about transplantation. So this is an interesting case. This is infected tooth, and there's the deciduous tooth, and the boy wanted to save his tooth, so we extracted this deciduous tooth and transplanted this one. And after extraction, we remove the bone with piezoelectric surgery, and you can see this kind of bluish thing. That's sinus membrane, a macular sinus membrane, and I lifted the sinus membrane via the extraction site, and then I put the infected tooth on the into the sinus membrane with bone graft. This is published for the International Endodontics Journal, and we do the follow-up this case. But usually we do autotransplantation when we fail the orthodontic movement. So this is the failure case of surgical opening. There's an infected tooth, and we try to move the infected tooth, but it was failed. So there was an open bite at the site. So we opened the flap and positioned the infected tooth at one time. So this is the operation thing. So there was a full coverage of the bone. You can see the direction of the root like this one. So at this case, the root portion, root was curved like this one, and we make the biomechanics like this one. The tooth may come out, but it was different when we do the orthodontic procedure like this one, but root was curved like this. Okay, so when we do, even though we do the very hard orthodontic movement, there was a blockage of the curved root. So that was the cause of the failure. So I grafted like this one. This is another case. very similar case with young age, but when we attach the two buttons, the button fallen out like this one. And so we did once again, but it was fallen out again, 2 times. So we did this kind of auto-transplantation at one time. So I always told the patient and the parent, there may be a chance of failure, and then after when the tooth has not moved, we will do another kind of thing. Then maybe a transplantation. But transplantation is very difficult. Extraction is difficult, and endodontic treatment is also difficult. So always we have to do the 3D model, and the surgeon have to do the technique. So there is a lot of running curve should be needed. So this is a thing, and I will show you some failure cases. In the finalized lecture. Okay, this is another failure case. The patient want to pull out this tooth, and we do the surgical opening procedure, and then attach the appliance like this one. But the tooth doesn't move at all, so we do the secondary procedure like this one. The cause of the failure of traction was here. The age was very young, 9 and 10. There was a high ability to regenerate the bone. The bone tissue was engaged on like this around the wire. That means even though we do the orthodontic force, the bone is engaged inside of the wire. So at the reopening procedure, I removed all bone tissue around next thing, and then the tooth has come out. This is not 100% of failure, but you have to keep in mind there may be need of second procedure of surgical rescue surgery. This is another failure case. This is a real failure case. So this infected canine was tried to save, but when you do surgical opening procedure, the teeth doesn't move at all, and there is open bite in the anterior tooth. The cause of this kind of thing is curvature of the root. You may see the infected tooth on this area, but you can see the root portion at here. So, considering this CT, the tooth was shaped like this one. Okay. So when we make the force to distalize the canine, there was a blockage of the movement. So we have to remove the tooth, and at that time, the vitality was lost in the lateral incisor. So we had to do additional endodontic treatment, and then we put the implant on here. So this is final thing. So I will do another thing, but this is my final slide. So once we make the treatment planning, we have to consider the risk and benefit to save the natural or the infected tooth. And then what can I do is not a big deal. What is the we have to do the patient-centered treatment planning, and we have to consult the specialist whether we save the tooth. And there's little guideline or something, so myself and Dr. Lee is working on this kind of infective tooth or surgical opening, so you may see some academic literature later. But before that, if you have any question, I will tell you my email later, but anytime you can discuss about the infected tooth like this one. Thank you.